we are joined today by Professor Anat Loewenstein. Welcome to you. It's always a pleasure.
Thank you very, very much, Cheryl. It's a pleasure to be here and just chat with you.
Absolutely. We're talking today about this month's COPHy conference, which is being held in Poland, and
Mhm.
would love to talk to you. I know your presentation, you're kind of designated the no perspective for this particular topic regarding treat and extend will continue to be the preferred treatment strategy in the era of sustained drug delivery. So I guess I will just jump right in and ask you, from your perspective then in this session, will treat and extend remain the preferred treatment strategy in the area of sustained drug delivery for retinal diseases?
Thank you very much. So, over the years, we've learned to adapt the treat and extend regimen for the management of our patients with retinal disease, be it macular degeneration, diabetic retinopathy, or vein occlusion with macular edema. And we've learned to see that when you use the treat and extend methodology, the number of injections is not different than when you use the PRN approach. However, the number of visits is a bit lower because you kind of come only for injection. Every visit is an injection. I think that things changed a bit now when we are talking about sustained delivery regimens, that some of them might incorporate fixed regimens, like every 6 months, which might be the way to think about in some of the TKI inhibitors, or refill every 6 months, like was tried with the PDS. So the treat and extend might not be the best way to go. Even if with the treatments that are just long lasting without slow release devices such as faricimab or aflibercept 8 milligram, then sometimes you don't really need to do the extension in order to get to the longer interval, but rather you can give the loading dose and then just try and extend it. It's actually switched to be more of a PRN approach. Another thing that I want to say, that because we are really seeing that the homo-CT has a great potential in the management of our patients with retinal disease, the homo-CT actually is built on the concept that whenever there is a little fluid, an alert is sent to the patient and to the physician. So when you look at that, then it's more of a PRN. However, it's a real PRN. And of course, we're waiting for a protocol AO of the DRCR-NET that will look at these patients on a long term, that will tell us if actually this very, very accurate PRN gives better final outcome and or less injections as compared to the treat and extend approach.
Is there anything you'd like to add, like taking a little bit of a deeper dive into that in terms of how does treat and extend compare to sustain drug delivery in terms of visual functions and disease control?
Yeah, so I think that when we looked at the treat and extend, it was kind of paired to the previous generation of anti-VEGF agents, and now we're talking about a newer generation anti-VEGF agents, and it's you don't necessarily use an exact treat and extend regimen, even though you could theoretically you could extend by 4 weeks as compared to 2 weeks that we used in the previous treatment. However, many times you would just, after the loading dose, you would not just continue with the same interval and just extend it, but rather try and extend immediately after the loading dose. And I think when we look at that, the results are kind of better in terms of, at least in terms of treatment interval, not necessarily efficacy. It's very similar. They're kind of better, but it's a different drug, so it's difficult really to compare. And when we are talking about the TKIs, then the TKI has the potential to hold for many months. And in this case, treat and extend is not really relevant.
What are some of the considerations, whether it's in terms of safety, logistical, or patient adherence, considerations for each approach?
Yeah, so I think that treat and extend has been proven in a way to have a little more compliance than the traditional PRN. But I think that if we have a longer acting agent, such as the genetic therapy or TKIs, or even the drugs that we have today, like aflibercept and faricimab, then much better not better visual acuity results, but when you consider the number of injections, then a better final outcome with a smaller number of injections. Um, so I think that the issue of compliance becomes much easier if you're looking into a treatment that will be given every 4, 5, 6, or 9 months even. So we will have less issues with compliance. I think there are still logistical issues because you don't necessarily want to not see your patients for more than 3, 4 months. So you might want to see them in any event after a certain time period. And also, you might need a safety net, such as can be given by the home OCT, because you don't really know that if a patient was able to be extended for a longer period of time, it will always be the same extension. So it's still a matter of when will you want to actually see your patients.
Could sustained drug delivery or even other emergent urging modalities replace treat and extend as a standard of care?
Absolutely, I think that sustained drug delivery and TKIs, well, TKIs are actually on a sustained drug delivery, the ones that we have today, and the slow release devices such as the PDS and genetic treatments, they have the potential of giving a very long-term treatment that needs to be given once 6 months, once every 9 months, once a year, and even longer. And then the treat and extend methodology becomes a little obsolete because you're not giving something and then extending, but rather giving a very long-term drug upfront. So yes, I think that we have new developments that will actually go against treat and extend.
Is there anything else to add that I haven't asked you or you feel is really important for the audience to know?
I think that it's important to know that we had very good treatment for the last 15 years for macular degeneration and diabetic retinopathy that really saved the visual acuity of the patients that before that became blind and after that this did not become blind anymore. And the regimen was not perfect, be it PRN or treat and extend. Now we have longer acting agents, we have slow release devices, we have genetic therapy, and we are able to go now even further to the benefit of our patients. And also for relieving the burden from the system, from the patients, from the caregivers, and from ourselves.
Well, Professor Loewenstein, thank you as always. We really appreciate your insights.
Thank you, Cheryl. Thank you very much.